Well, hello there, listeners. It's Susie New from the Australian Society of Anaesthetists, and thank you for listening to our podcast. It's called Australian Anaesthesia, and it's where we talk about all things relevant to anaesthesia in Australia. In this episode, I'm chatting with Dr Vin Gamage. Dr Gamage is a general practitioner and is also an authorised prescriber for methadone for people who are dependent on opioids. At the time we had this conversation, he was also training to become a GP Anaesthetist. And as part of that time as a trainee, he gave an excellent presentation on long-acting injectable buprenorphines. I'll say that again because if you're like me, I hadn't heard about these medications before. It's buprenorphine and it comes in a long-acting or depot formulation that can be administered via a subcut injection. So in this episode, that is exactly what we are talking about. I also dive into his perspective and experience of prescribing methadone, and he brings to this episode so much knowledge about the history of addiction medicine and how these opiates were discovered. We also, crucially for us anaesthetists who work in the acute care setting, talk about the various ways you might manage a patient who comes in with acute pain who happens to have a long-acting injectable buprenorphine in their system. All right, let's get into it. Thank you so much for giving up some time. So we're talking this morning about long-acting injectable buprenorphines. I really loved the talk that you gave about it recently.
Oh, thank you.
Before we go into it, I wanted to ask, have you had that experience in general practice of looking after patients who are on these medications?
Not so far. So far, what I have is patients who are on methadone because these products are quite new. And we don't have much experience about them. So it was a good thing that I did the presentation. So for my own sake, where I could research into how these things work and what problems we would get to face in the near future.
Yeah. I don't know anything anymore about what happens in the community. But for you to prescribe methadone, do you need a special license to do that?
Yes, you had to do a training called method training. Each state has their own licensing authority. So in Victoria, it is drugs and poisons there are two days courses. So once you do them, you become accredited prescriber. There is a limit to the patients, as I remember. I think it was 5 patients that you can look after at one given time.
Really?
Yeah, if you are in a public clinic, I think there's no restrictions. You can keep looking after any.
I wonder, why do you think that is? That's interesting.
Well, I think it comes from the history about these restrictions. If you want, we could dive into that. I think it was a bit of a fascinating history, how these long-acting agonist therapies were developed and how they evolved.
Yeah, I'm curious. I love this context because we see the other end. We see the patients coming in on methadone and we obviously manage them in the perioperative setting. But as I said, I don't get a glimpse very often into what happens the rest of the time.
Yeah, so initially methadone was developed from pethidine, which was invented in 1937 by German chemists. So they were trying to develop more chemical structures based on pethidine.
Yeah.
So in the pursuit of that, they developed this compound, which was called compound 10820, which would later become methadone.
Yes.
So they synthesized it, but never had time to further develop or research into it because it was World War II.
Yes.
So World War II ended and all the German patents of all the compounds and things were requisitioned by the Allies.
Yeah.
And interestingly, in the US, the Department of Commerce sold this patent for this agent for just $1 for any pharmaceutical company in 1940s. So many companies went into research of this compound and they were integrating that with the products like cough medicines, pain medications. So then when it reached 1947, that's when they gave this compound the generic name methadone. So initially, as of any other medication, they were trying to use it as an analgesic product.
Yeah.
But the problem was from 1950 to 1960, that was a post-war period after the World War II.
Yeah.
Many soldiers were there who were treated with morphine. There was a huge addiction problem with morphine going on.
Yeah, right.
As a result of the morphine issue, a newer agent was introduced to the market, which was called heroin.
Yeah.
Which they thought would be less addictive, which proved to be wrong.
It was a common headache medicine in the 60s. It was like what you took, like a Panadol.
Could be, yeah, could be. I've seen some old advertisement to say, okay, if you're tired with duties at home, just take a couple of meals of this in with your tea or something.
Yeah, and it was heroin. It was widely marketed.
So what happened with heroin was, so the morphine epidemic became a heroin epidemic. So during this time, 1950 to 1960, the deaths from overdosing heroin reached up to 5 to 6-fold of the normal overdose deaths. The problem was all those deaths, 75% of them were young people. The mean age of death from overdose was just 29 years. So in the pursuit of a solution, they were trialing all the chemicals that they had. And they used methadone initially as an inpatient program. It was a 10-day inpatient program, which they dosed very high doses, like 200 milligrams 3 times a day.
Yeah,
they thought that would break the addiction, and then they were released back into the community.
Oh, wow.
Which proved to be wrong again. 90% of the people relapsed back.
Oh, exactly. Oh, my goodness.
So that's what would happen, isn't it? So that was the length that they went at the time. But two husband and a wife doctors, they worked for Rockefeller University Hospital. They had a different opinion. They thought that it's not just breaking the cycle. There should be something else going on here. Maybe there's a deficiency of these chemicals in their brain, or they're metabolizing it early. So the very early thoughts of addiction medicine was born there. Then they had this different clinic. They somehow managed to start a clinic, which was an outpatient clinic, where they continued to give this adequate dose to stop the withdrawal effect from heroin, which seems to be successful.
Right.
So in that time, with the higher drug addiction and drug death rates, also hand in hand, the crime rate was going up.
Yes.
So the Nixon government at the time, they had to do something about it. So when they researched what they can do, this was the only clinic which was proving that it had something.
Right.
So they had to embrace that clinic, what they were doing. But at the time, addiction was in the general population, what they were thinking, it is happening because of a weakness in the character or weakness in judgment and so forth. They never thought that there's a biopsychosocial effect of it. So most of the government officials are not very open to it, but they have to embrace it because that's the only clinic which is showing results. So that's why all these restrictions came in about these dispensing and everything, which I think formed the core principles of a methadone clinic even nowadays after 60 years, where their lifestyle is totally changed. So I think that gives us a bit of a perspective. Why are they controlled so much?
Yes. And so as a result of that's why a GP can only have a certain number of patients who are on methadone on their license, unless you're in a drug and alcohol clinic. Interesting.
Yeah. And then the methadone was being used in the US for these reasons at the time. And then around 1966, this was in England, they were in the pursuit for this perfect morphine molecule where they want an excellent mu receptor agonism, which would kill the pain without any adverse effect like nausea, vomiting, and so forth.
And addiction. I mean, that's the golden opiate, isn't it? One that's very effective on the mu receptor, great analgesia, but not addictive and no other side effects.
Exactly. So in this pursuit of this perfect morphine, they invented this new molecule called buprenorphine. Again, it was used as an analgesic in the initial stages. And then by late 70s and early 80s, even the injectable and sublingual forms were produced. So I think what made buprenorphine become more popular was a HIV pandemic in France, which happened around 1994.
Right.
The rapid progress of HIV and AIDS at an epidemic level, they had to stop the needle sharing at any given cost. Until the public health response could kick in and educate the people and do all the things, which would take some time. So what the French did was they allowed any GP to prescribe sublingual form of buprenorphine without any restriction, knowing that there would be a significant amount of drug diversion. So at a cost of drug diversion, it actually stopped the pandemic progressing further, which was again fascinating.
That does your sort of public health mind in, doesn't it? It's which public health issue am I going to tackle? What an interesting approach there.
Yeah,
wow.
I think they must have thought buprenorphine is a bit safer than methadone. So maybe that was what's back in their mind.
Yeah.
So with that, it got the momentum that this molecule, it can be used in many other ways. Yeah. And then the US got interested about this molecule again. So they started to trial it in their drug addict patients, and particularly they were researching into that. So they were having nicer results. So they thought, okay, the buprenorphine molecule has partial mu agonism. So it doesn't give you the high or analgesic effect as any other molecule.
Yes.
But it attaches to the mu receptor so well for a very long period of time. So it's kind of the best that we have at the moment. But still the problem was the formulations were sublingual. So they had to dose it every day. So the patient had to come to a clinic.
Yes.
Then they were looking into, could we make it long acting? The first attempt of that was to give a subdermal implant. Yes. Which is something similar to Implanon that we use for contraception purposes. So they would do a little incision, insert the thing.
Yes.
And then it lasted for 6 months. But again, it wasn't that popular.
6 months.
6 months, yeah.
Oh, whoa.
And then it wasn't that popular among the patient because it involved a minor surgical office procedure.
And just remind me, when was this being introduced or being trialled?
I think it should be around 2000.
Wow. So implantable buprenorphine's been around for 20 years or more.
20 years or so. Yeah, that's right. And
wow.
Next to the molecules that we are going to discuss more on today, they were developed around 2014 and 2018. They are much more recent.
Yes. Okay. But this concept of having implantable buprenorphine's been around
for a bit. Yeah.
That's really fascinating. Let's just, while we're talking about the mechanism of action, just dive into that a bit more, because that's really important as to why buprenorphine is very attractive, because it's only a partial mu agonist, as you said. So people don't get that high, but they hopefully get some effect.
Yeah.
But it binds so strongly.
That's right. So the comparison from methadone was the half-life of methadone is up to 30 hours. This is up to 60 hours. It can be variable, but almost double that. And the other thing is less risk of deaths relating to overdose.
Because of the partial activity.
Partial agonism.
Okay, so you don't get that respiratory depression that you get with a very strong mu-opioid agonist.
Yes, that's right. And I think the other thing is the retention rate of the patient. So with methadone, it was from 40 to 50%, whereas with injectable buprenorphine seems to be 50 to 60%. So the highest ever that they could retain patients on.
And you're saying retention rate, that's the
people who come back to get the same injection again and again, so that they're happy to be in the program without going back and using the other.
Yeah, right. Can I just go back to methadone briefly? People who are on methadone need to collect their dose daily. Is that right?
It is, yes, correct.
And they need to go to the pharmacy and collect it and have it at the pharmacist?
Exactly. Yes. So it's a designated pharmacy. They cannot go to any pharmacy and ask.
Yeah.
So the pharmacist has to register the patient from their end so that they have a constant supply of this medication.
Yes.
Every morning at a particular time, the patient goes in, have the tablet solos in front of the healthcare provider, and they have to open their mouth and show that there's nothing.
Wow.
It is kind of intimidating, but that's how the
I could imagine there's a bit of stigma around all of that as well. And do you, as a GP who's providing that script for them, is there an obligation for you to review them at a certain period, or how long can you prescribe for example?
Look, I think as a GP, the role is just to be the prescriber. The patients get reviewed intermittently by the addiction medicine specialists who would give us a guidance about how long this has to be going on. But it could be many years, particularly because most of these patients have a dual diagnosis from a mental health issue or psychosocial issues. Yeah, it's quite sad, and sometimes it could be 10 years or so.
Oh, wow. And do you always manage these patients in conjunction with an addiction medicine specialist? So you wouldn't initiate treatment yourself necessarily?
You can initiate, but I would like to get a proper plan. So personally, I would like to involve someone.
Okay, but it's not a requirement of your credentialing.
Not a requirement legally, yes.
And it must be, well, I don't know, inconvenient is the word that comes to my mind if your patient wants to travel or move. I can imagine sometimes these people don't have stable accommodation and lifestyles and so forth.
Yeah, the other thing is, even if they want to go for a job, for example, if they want to become a tradie, the tradie jobs start around 6 o'clock in the morning.
Yeah.
So I think one of the other benefits of these injectable ones are higher employability of the people. Then they don't become a burden to the society.
Yeah, exactly. Getting a higher level of function. All right. Well, maybe that's a good segue into the injectable long-acting buprenorphines. Is that the flavour, do you think? Like if you've got someone who is on a very stable amount of methadone, would you ideally be trying to move them on to injectable buprenorphine because of that potential for greater employability and less stigma and those sorts of things?
I think it depends on the patient, isn't it? Because one of the things is, as I mentioned before, because it's a partial agonism, they don't get that high feeling from that. So some patients would not like that.
Right.
So they would think that we are trying to change the medication unnecessarily. I think it should be a combined decision with the patient and the clinician.
Good thought.
What we can do is, we can tell them that there is a new option so that you can just have this injection once a month. Yeah, you can do whatever things in the month and just come back for the injection. Some people would like that, the autonomy and independence that they get with it. Some patients might not.
And again, how does it work with the injection? Do they need to come back to you as a GP or you just give them the script? You know, who does the injection?
We can give it in a GP clinic or else at a pharmacy, accredited pharmacist who could inject things. These are subcutaneous injections.
So there's 2 injections available in Australia.
Exactly. So I'm just going to mention the brand names because that's the commonest name. So the generic name is long-acting injectable buprenorphines.
Yes.
I don't have any commercial interest of them, but...
Neither do I.
Yeah. First thing is called Sublocade, which was invented in 2014. It has a buprenorphine mixed in a biodegradable polymer mix, which they call Atrigel. That's how they make it disperse slowly over a month's period. And then it started with 2 solutions. One is 100 milligrams and second one is 300 milligrams. So by 2018, they came up with another brand, which is called Buvidal in Australia.
Yes.
And another names in overseas. So Buvidal has a different technology. It looks like it crystallizes the buprenorphine to a slowly liquefying form of some sort. So they call that technology the fluid crystal technology. So different technologies, but it's the same molecule.
Okay, so there's crystal buprenorphine and there's gel buprenorphine.
Fluid crystal Buvidal, yes.
Okay, so they've been in Australia since 2014, 2018, respectively?
Sublocade was invented in the US in 2014. Buvidal came into market in 2018. But I think in Australia, it came very recently over the last couple of years.
Okay.
Has been in the US for a while.
I see. And so what are the main differences between those 2?
So with Sublocade, it has just the 2 formulations of the 100 milligrams and 300 milligrams. It's a monthly formulation. So you have to dose it every 4 weekly in the ideal condition. It needs refrigeration. Whereas Buvidal does not need to be refrigerated.
That's important.
Yeah. And Sublocade, which is it's an older, longer-acting version. It needed a 19-gauge needle, bigger needle. So
that's big.
It is big. And therefore, it's only licensed to be used in the anterior abdominal wall as a subcutaneous injection. In contrast to that, the Buvidal has multiple formulations. It has 8, 16, 64, 24, 96, 32, and 128. So,
wow.
And also Buvidal, it has 2 other ways. So there is a weekly formulation that you can give. And there's a monthly formulation as well, whereas Sublocade is only monthly and it does not need refrigeration. And the Buvidal needle is 23 gauge needle, which is nicer.
Much more.
It can be given in the upper arm, thighs, or abdomen.
And if you were going to start someone on these medications, how does that process work? So you've got someone who's been on methadone on a stable dose, and they say, yeah, actually, this is not working for me going to the pharmacist every day. If I could get a monthly or a weekly injection, would love to try it out.
So the first step of that is to convert them to sublingual buprenorphine dose. So we had to do the comparison and them a comparable dose, and for 7 days to make sure that that's their right dosage. So depending on that daily requirement over that 7 days, there's a dosage guide for Buvidal to say, okay, if the patient is using 8 to 10 milligrams of buprenorphine orally, start them on either weekly 16 milligrams or monthly 64 milligram formulation. With Sublocade, the initial thing was they were going to give 300 milligram injections first anyway, and then bring them down to 100.
Okay.
But I think in the US, they're using the 300 as an ongoing because there's so much use of fentanyl. So to counteract that, they need very high doses. So.
Right. But you'd still start them on the 300.
I was amazed, but it looks like it's safe.
Seems like a massive dose, doesn't it?
Exactly.
I suppose you're relying on that gel formulation and the slow release.
That it will slowly release.
Do we have an idea? So you're implanting 300 milligrams into their anterior abdominal wall. This is in the case of Sublocade. What their average daily dose is that they're receiving?
It should be at least 8 to 10 milligrams.
I see. So if someone were to have 300 milligrams subcut of Sublocade, you could expect that they're getting at least the equivalent of 8 to 10 milligrams daily.
Yes.
So in terms of making that transfer of someone onto one of these injectable buprenorphines, again, that could be done by their GP.
I'm not entirely sure about that because I haven't done it yet. I think at the moment, this is offered in the public clinics.
So the addiction medicine clinics.
And I think as it goes in the next 5 years or so, I reckon it would become much more available and would be kind of more liberalized.
Yeah, as we get more experience with it as clinicians in Australia. So if anyone out there happens to be listening and is on methadone and is interested, perhaps don't go speak to your GP about it, or maybe do, but maybe you need to see an addiction medicine specialist.
Yeah, that's right.
So I suppose there's some of the key differences in terms of how often you can give it and where you can give it, the size needle, those sorts of things. That's some pretty key differences. Are there any other key differences between the two formulations?
The other thing is about the flexibility of dosing.
Oh, yeah.
You can give it 2 days before if you think that we have had the injection 28 days before.
Oh, in terms of if you missed a dose, yeah.
Yeah. So you can have it on the day 26.
Ah, yes.
For up to 2 weeks later.
Oh, okay.
It gives a very good flexibility. But I listened to another podcast on addiction medicine. They say the experience is they can give it from the 3rd week onwards without any problems. So that gives a very wide window of flexibility for the patient.
Yeah.
Isn't it?
And you don't remove the previous implant.
No, it's biodegradable. So it slowly degrades over the next 3 months. So they're changing the quadrant in the anterior abdominal wall that they give it. So, by the next cycle, it should be gone. You should not be able to feel it.
I find that a bit... Let's just walk through the logic. So just say I'm on 4 weekly buprenorphine injections. If I, for whatever reason, and I can't get onto it for another 2 weeks, it's okay to have my next one at the 5 or 6 week mark.
Yeah, exactly.
So presumably that initial injection is having some effect.
Yeah, that's right.
And then if you give me a second one on top of that, am I not double dosing?
No, it looks like maybe because of the safety of the therapeutic window, the concentrations, maybe that's why they can do it. And some of the patients, because the effect of the medication will be weaning off day by day, some patients would get the cravings. That's what the addiction medicine specialists, they say from about 3rd week onwards, people would start to get the cravings. So it depends on the metabolism as well. So in some patients, it might need to be dosed earlier. Yeah, I think that's the key difference there.
And I suppose it makes sense. Well, you don't have a defined offset of action with these sorts of medications. And I suppose it gives people that flexibility, particularly with the 2 days either side, that if the day that you're due falls on a weekend or something like that, you can bring it forward or move it back.
That's right. With the Buvidal, the flexibility dosing is for the weekly injection, it is plus or minus 2 days. So you can have it on day 5 or day 9. For the monthly injection, it's plus or minus 1 week.
Yeah.
So a week before or week after.
Yeah, gotcha.
So if you go more than that recommended time, you'll have to start it again.
I see. Because starting them again would mean going back to sublingual buprenorphine.
Yeah, because what usually seems to happen is they would have to use something because they would be getting the withdrawal effects and then it tips them over.
Okay. So let's move on to the meaty part for anaesthetists, which is what do we do when we have a patient with one of these new medications, injectable long-acting buprenorphine. Buprenorphine makes pain management more complex in the perioperative period, and now this is longer acting and it's been implanted. What are some of the approaches that we can use for managing patients with these medications?
Yeah, exactly. Life happens to everyone. So these patients who are on long-acting buprenorphines can have a fracture, can come to you for
appendicitis.
Surgery. Appendicitis, exactly. So the problem there is, the tricky part is how would you manage their pain when they have a molecule in their system already which has firmly bound to the mu receptors. I think there are ways of managing that. First thing is you can slowly keep giving morphine or fentanyl like any other mu receptor agonist, but this should be a very slow process. You would need a very high dose. So keep giving until you start to get the response. So if you have a very high concentrations, it would displace the buprenorphine molecules from the mu receptors, and then the new molecule might attach there and give you the mu agonism. But it is very risky, and I don't think it can be safely done in a general ward. So
no.
That's going to be a problem.
Yeah. So we're talking doing it in a monitored area, ED, ICU anesthesia. And when you say slowly, anaesthetists, we work on giving about 5 drugs within 10 seconds. So what time frame do you think you might titrate someone with fentanyl or morphine?
Maybe 2 hours if you keep giving up to 10 milligrams of oxycodone and then wait at least an hour to see the effect of it.
Yes.
And then you can titrate it again. Because once you've given it, you cannot bring it back. You have to reverse it. That's the problem.
Yes. Well, can you reverse it? Can you give naloxone in that sense? Just say I've got
probably naloxone should work, isn't it? Yeah. Because it would reverse the opiate part of it. Yes.
It's you're in uncertain pharmacology land, aren't you? It's
exactly, that's correct.
Because I can imagine, just say you've got someone who's come in, they've been involved in a motor vehicle accident, they're trying to quickly titrate some analgesia. You're giving IV oxycodone. It would be easily overwhelm them to the point that you are facing opioid overdoses, couldn't it?
Yeah, exactly. I think that's why we should consider the next option, which to use ketamine, because it uses an NMDA receptor antagonism. So it could be a more safer option. And if you keep giving the analgesic dose of the ketamine 0.1 to 0.2 milligrams per kg, that would be a way to manage these patients.
Yeah. So use an alternative pathway.
Pathway.
Yeah. Perhaps a bit of clonidine.
Yeah, exactly.
Non-steroidals, paracetamol.
All the simple
analgesics.
Yeah, plus this.
Regional anesthesia.
Oh, regional. Yeah, exactly.
We love local.
Local. Yeah, that should work the best.
So find another pathway,
If find another pathway, the second and third one would be to use a higher affinity molecule. So fentanyl seems to have the highest affinity over buprenorphine to the mu receptor. And if you use fentanyl rather than oxycodone or morphine, it seems to give some effect earlier. It seems to be a bit safer than giving a blind doses of other opiates like oxycodone and morphine. I've spoken to a couple of pain management doctors who said, theoretically it is correct, but they would directly go to ketamine because it's again,
just go for something more reliable.
More reliable. Maybe it's not reliable in every patient. So the advice was
And it's one of those things that in a laboratory when you can study affinity for mu-opioid receptors. Yes,
exactly.
When you're dealing with someone
with real patients,
it might be unpredictable. Yeah.
So there's another interesting one. The last option is you can extract this injection because it's in a subcutaneous thick gel form.
Right.
I think if the patient just had the injection like a couple of days ago, this would work the best. But if the patient is 3 weeks plus from the last injection, I think the chances are very low. So with a simple incision, you should feel where the bleb of this gel is, and you can do a local anesthetic around and then do a simple skin excision, and you can extract the whole thing out.
Wow.
And that should theoretically, that's one of the things mentioned in the product description that you can do.
So that's what the manufacturers recommend?
Manufacturers, recommendation,
Wow. And is that for both of them, both formulations that you will get this? Okay.
Out, yes. That's
wow.
Right.
There you go. So we might, at a push, need to practice some of our surgical skills and put some local in and excise. We should be able to palpate it.
Yeah, that's right. So if you cannot, you should not go hunting for it. No. But if you could feel it, you can take it out. And then because that molecule is out, you can dose as any other patient, hopefully. And the pain would be much more well controlled.
Well, there you go. And that's something useful to keep in mind if we ever are in this situation, managing these patients and exhausting our other options. Or maybe, as you say, as an early option, if we know that someone's going to potentially have a quite complex course with their pain.
Yeah, exactly.
Wow.
What they recommend is once you take that out, it's your responsibility to dispose it off because it has a medication in it.
Yes, of course. Yes, whole lot of things there, isn't it? It's also tissue and all of that. Yeah. Oh my goodness. Is there anything else that you have discovered in your path with long-acting injectable buprenorphines?
Look, I think it would become the main choice in the years to come. It's not the perfect product yet, but it ticks most of the boxes for a longer-acting agonist treatment. The patient convenience to come to a place once a month or the flexibility that it gives them is huge.
Yeah.
And then because they are not meeting up with a healthcare provider, I think it would cost less to the system.
Yeah, that's true.
Because, it's 1 month. Now you have to schedule someone once a day to dispense these medications. So less cost. And as you mentioned before, it seems to increase the rehabilitation and employability, which would ultimately, the patients would become less burden on society itself.
Yeah. And all those impacts of being part of the workforce and, positive mental health impacts of that.
That's right. And it seems to have the greatest adherence to the treatment program so far. And because it's an injectable formulation, the chance of diversion is very unlikely.
True.
Yeah.
I hope that people listening to this podcast don't decide that they can excise it out of other people.
Excise it out and
try and inject it into themselves. That would cause so many issues. So many ways, on so many levels. Do you know much about, obviously a bit early to say with injectable buprenorphines because they're so new in Australia, but obviously this is done in conjunction with the patient, but is the long-term goal to get them to a place where they're going to maintain and potentially be on this for the rest of their lives? Or are you ultimately trying to get people off all opiates?
Yeah, ultimate goal is to come off it. But the thing is, it could be very long time, sometimes 10 to 20 years. Some of the patients might not get off them ever.
Yeah.
Because their psychosocial or mental health conditions would not improve. When I spoke to addiction medicine specialists about the methadone and so forth, they seem to be very relaxed about it. They say, what you're doing is controlling the addiction with this medicine, which kind of controls, they're safe. They're not going to harm anyone. It's beneficial for the society because they're not committing crimes and so forth. It's just a maintenance therapy. When the patient is ready, their psychosocial things are now in a better position. They're in a better mental space.
Yes.
That's when the patients come and tell them, okay, I'm ready, what we can do to get off them.
Yeah.
So it's long-term follow-up and the patient should trust the doctor, which again, sometimes it would take about 18 months to build that trust.
Oh, absolutely. I can imagine like some of them might have had quite traumatic experiences with the healthcare system in general. Yeah. Oh, fascinating. I remember talking to someone about addiction and they said, once you're an addict, you are always in recovery.
Definitely. Yeah.
Whatever it is that you're addicted to, whether you're using it or not. You could be a dry alcoholic or a non-using opiate addict, but you're always in recovery.
Biopsychosocial aspect of it, what they say is, if you have even a close family member who has an addiction problem, you should be very careful too, because you have most of the tendencies, you're brought up with the same surrounding and so forth. You have the similar genetics, and you should not test them and go on a slippery slope.
Oh, that is a very, very good point. Because I do know it's much more common than we think out there in terms of all the various substances that people can get addicted to. Oh, look, but anyway, it's been fabulous talking to you. This has been so educational. As I said, this is not my field at all. And I think there's been some really useful information there, because we may hopefully, as you say, see more of these medications in our patients that are coming to us. So it's good that we've got an approach to handle it.
Yeah, hope so.
Cool. Lovely. Thanks, Vin.
Thank you very much, Susie.
I really enjoyed talking to specialists from other fields of medicine, and I hope you enjoyed listening to our chat as well. We have so much to learn from each other. Now, I don't know about you, but when it comes to talking details of pharmacology and comparing medications, it feels a little bit like an exam question, and I kind of go into exam mode. So in my mind, as I was listening back on our conversation, I had this table of comparing and contrasting different medications and so forth. And sometimes this information is just a little bit easier to absorb visually, which is why I'm pleased to let you know that Vin has kindly shared his slides with me from his presentation, and we have patched them together as a video to go along with this podcast. You can find that video on the ASA website. Of course, I'll put a link to it in the episode notes below. It's only a simple video, which is why I didn't mention it at the start. It's more of an aid memoir, as I said, in case you just find it easier to see this information written down. It also includes some references in case you want to go off and learn some more. And one of those references I found really interesting is called the Australian Injecting and Illicit Drug Users League. I've never heard of them, but according to their website, they advocate for the 4 million people who use drugs illicitly in Australia. So there you go. They have on their website a load of patient or consumer-focused resources. And I'll put a link to that website in the show notes too. Well, anyway, I hope you learned something. I hope you enjoyed hearing perspectives from another specialist. And I also hope that if you happen to be listening and are also in recovery, whether it be from opioids or alcohol or whatever, that you're doing okay. And wherever you are in life, I hope you are keeping safe and well out there.
This has been Australian Anaesthesia, produced by the Australian Society of Anaesthetists, with many thanks to host and editor Dr Susie Nu, with music by Soda Lime Music, sound and engineering by Bearview, and graphics by the ASA Communications team. For more content, please visit www.asa.org.au.